Welcome to a new episode of IR Pathway. Today, we are going to discuss the percutaneous drains. These are among the most requested procedures in IR, although they may not be considered a high-end IR procedure, but they can make a big difference for the patient if someone in the hospital knows how to place them. So, a drain is simply a tube inserted to remove fluid from body collection and bring it outside. So, for those hearing about the idea of drainage for the first time, let's go back in time to the 50s and 60s. At the time, if there was any kind of fluid collection in the body, whether post-operative or from any other cause, the first line of treatment was always antibiotics. But if antibiotics failed, the next option was surgical exploration. A surgical incision was made like this, and the collection was drained directly. Usually, a surgical drain was inserted and secured to the skin with sutures, okay, like this, to keep it from slipping outside. That was the situation up till around the 70s, and with advancement in the imaging technologies, the concept of percutaneous drainage began to emerge. And the idea was simple. Instead of making this large surgical incision, if we could access the collection from the outside of the body and leave a catheter or a drain in place, the drain could remove the fluid from the collection to outside, whether attached to a bag, bulb, or any drainage system we use. Now, two important elements had to be developed for drains to become part of IR. The first was a proper retention mechanism, something that would keep the drain from slipping out once inserted, because if it came out, we would have to either place another drain or even perform surgical exploration again. So, a reliable retention method was essential. The second element, as with anything in IR, was design modifications to suit the different types and uses of drainage. The most common retention mechanism developed for drains came from the surgical drains, which were simply a straight tube like this with side holes to help to collect fluid from the cavity. But with IR drains, a few important modifications were added. The tube would go in straight, then curve at the end like this. This bend was the first and simplest retention mechanism, because once the curve sat inside the collection, pulling on the drain from outside would not let it come out. This drain became very popular and was used in many drains, okay, and it's known as pigtail catheters. They were called pigtail because the curved end looked like a pig's tail, and that's where the name came from. It was one of the earliest catheter designs. Okay, and here as an example for the pigtail catheters, as you can see, it has a characteristic curved pigtail shape. Okay, and to achieve this pigtail configuration, the catheter design had to include a way to form and hold the curve. One key feature I would like you to know is this string here. This string runs from the along the entire length of the drain, connecting the hub to the curly tail. So once we insert the drain and form the pigtail, we pull on this string like this. As you can see, pulling it make the pigtail curl into shape. It becomes tight and fix it just like this. After that, we twist this part and lock the drain in place. When we first insert the drain, the string stays pulled tight, so the pigtail remains closed. Okay, it stays retained in the cavity like this until it's time to remove it. The removal techniques will be explained later. Okay. So this was the first major concept behind achieving self-retention. Of course, there are different types of catheters. This one, for example, is the Skater catheter from argon. Many companies manufacture these drains, and most of them work very well. The retention mechanism may vary from one brand to another, but in this, for example, it's controlled by a string that warps around, while in other companies like Cook, for instance, the drainage system is slightly different, like this one. Here, dragging mechanism is modified, but still we have the string running through the catheter. Only in this case, the string warps around the handle, as you can see. Okay, when we close this handle, it locks the pigtail in place so it doesn't slip out of the collection. There are other ways to secure a drain beside the pigtail. One example is the Malecot catheter. Okay, it has wing-like extensions like this. Okay, so the catheter stays in place and doesn't slip. Okay, I want to say that all these types of drains fall under a generic category, okay, called multi-purpose drains, or MPD, or all-purpose drains, APD. Okay, they are called so because we can use them for many situations. For example, if I have a collection somewhere in the body, a pigtail can be inserted for drainage, even without a collection, like a hydronephrotic kidney, for example. We can still use a pigtail to drain the urine. Okay, same idea here in the liver with biliary dilatation. Okay, we can insert again the pigtail drain and drain the bile and so on. That's why they are called the MBD or ABD. Okay, but of course with new technology, we specified drains, more specified drains appeared for specific uses. Take hydronephrosis as an example. Okay, let me continue this diagram down to the bladder. Okay, a pigtail placed here, okay, works as an external drain, sending urine out to a bag. Okay, but the problem with this drain is that the patient must always carry a urine bag, which is of course inconvenient. So, as usual, modification was introduced to deal with this situation, and we came out with something called the nephroureteral stent. Okay, the nephroureteral stent or the nephroureteral drain. It has two loops. One lies in the renal pelvis, and the other loop extends down into the bladder. This way, it can drain outside or drain urine down to the bladder, provided, of course, that there is no urine output obstruction. So, what is the advantage of such configuration? If the patient doesn't want to use a bag, he can simply cap the tube here. Okay, when capped, urine cannot go down. Okay, cannot go out, so it flows down into the bladder. Okay, here's the actual drain. Okay, as you can see, two loops. Okay, we have one renal and one goes down to the bladder. If the patient capped the drain, okay, urine goes down into the bladder, and if he opened it, urine drains down out to the bag. Okay, this is the nephroureteral stent or internal external urinary drain. So if you hear those expressions, don't get confused. Simply, when we place a pigtail drain that permits urine flow outward, we call it an external drain. But when we place this type of drain, we call it an internal external drain or nephroureteral drain because it can drain urine either outside the body or back into the bladder. Okay, the same concept applies to the liver. Assume this is liver. Okay, like this, and we have biliary dilatation, and here is the CVD, common bile duct, going down to the duodenum. Okay, we can place a pigtail catheter like this, bringing it outward, so all the bile here will drain outside and collect it back. Or we can use internal external biliary drain, the same concept. Okay, it's a drain which extends with extension into the duodenum. Okay, so if the patient opens the drain for bag drainage, the bile will drain outside. But if he caps the drain, the bile will flow through the drain until it reaches the duodenum. This is the internal external biliary drain. Okay, and this is what it looks like. It usually comes with a plastic sheath to strengthen it during insertion. And of course, we will discuss insertion later in details. Okay, but in general, it's a tube shaped this way. And this marker here is usually seated at the access point, and this loop goes down like this. This is exactly how it looks. Okay, if the drain is open, fluid exits outside. If it's closed, bile flows naturally into the duodenum. Okay. Of course, nowadays there are more creative drains. I'm just trying to show you these types now, so you are familiar with them before we move on to other topics. For example, if the kidney is dilated, okay, here is the kidney, and down there is the bladder, and we don't want to place an external drain. Okay, of course, the well-known solution is that the urologist comes from below through the bladder and place double J stent. But we in IR can place a double J stent from an antegrade approach. Okay, so this is an antegrade double J stent. We can place it antegrade. Okay, we place it through the kidney axis, and it ends up fully internal. Nothing comes out. It's an internal stent. Okay, we call it the internal ureteric stent. It's a totally internal drain with nothing outside. Usually, you will just place it from below, but we can also place it antegrade. Now, one more point: if we have a multiloculated collection like this, okay, and we want to drain it. Sensibitations may make pockets non-communicating with each other. So, if we use our pigtail here, okay, like this, may drain only one pocket, but never drains this one. Okay, to fix this, some use a modified ABDL. It means taking a standard drain like this, okay, and adding extra holes with scissors, thus increasing the number of holes. Normally, the pigtail holes are only near the tip. Hopefully, you can see it here, okay, as you can see. There are no holes along the proximal shaft here, okay, so extra holes allow wider drainage. And so the external the original holes drain the main cavity here, okay, and the added holes help us with larger collections and can drain more collections at the same time. This is what we call the modified ABD or modified all-purpose drains. So if someone says modified drain, he means extra side holes were added. Now, let's move on to another topic, which is the indications of percutaneous drainage. First, I want to differentiate between aspiration, where we just pull the fluid out without placing a drain, and drainage with a catheter left inside the cavity. Choosing between them is a gray zone in IR. One radiologist may aspirate a collection, another may place a drain. But here are simple guidelines that can help you to take the right decision whether to aspirate or drain. Okay. The first factor, as you expect, is the size. If the collection is small, you can aspirate it directly. So, if it is under, say, 3 centimeters, okay, like this, needle aspiration usually resolve it, and you can send fluid for culture later to a guide for antibiotic therapy. Okay, it resolves completely. But what about largers? If it's more than 3 centimeters, like this, we will need to place a drain for continuous drainage over time. So again, size strongly guides aspiration or drainage. Okay, the second factor is the nature of the collection. Simple collections can be aspirated, okay, but multiloculated ones may look single on imaging, okay, yet contain partial septations that may only be seen on ultrasound, okay. So aspiration drains only the first pocket, okay, here, while the others need time and continuous drainage because they might be connected through very small openings. So simple aspiration won't be enough to remove everything, and these are the collections where we place the drains and modify them by adding extra holes and give it time to drain. We then usually connect these drains to a bulb under negative pressure, so the negative suction drains the collection over time. Okay, so for multi-regulated abscesses, it's better to place a drain rather than just aspirate. One important point surgeons always emphasize is the presence of fistula. Okay, if a fistula communicates with the collection, drainage is preferred over aspiration. This is commonly seen in the Crohn's disease patients, okay, and in diverticulosis complicated by diverticulitis, where a contained perforation and abscess are formed. So the idea here is, let's say that this is the colon here, okay, this is a colon. The idea is that this colon may develop a perforated diverticulum that communicates directly with the fluid collection. And as long as a fistula is present, it will never heal. Okay, the opening will remain. So if you only aspirate, the collection will refill within a day or two. So what is management? If surgery is not safe due to active inflammation, we can place a drain for continuous and immediate drainage. This continuous drainage gives a better chance for the fistula to close and heal on its own. And that's why we always stress that if there is a fistula, never remove the drain without the surgeon approval. If the drain is removed too early, the collection can reaccumulate within days. So this is always require surgical discussion. The same concept applies in cases of leakage, okay, whether it's bile or urine leak. For example, say here is the kidney, the ureter, and the bladder. With invasive pelvic tumors, especially advanced uterine cancer in females, a fistula may develop between the distal ureter and the vagina. Okay. In these cases, we place a drain for urine diversion. This directs urine straight outside once it forms and doesn't pass through the normal pathway. Okay, and this allows the fistula to heal spontaneously. Okay, so in summary, fistulas and leaks, whether bile or urine, are key indications for drains, not just aspiration. Now, let's move to another important topic, which is how to place a percutaneous drain. Okay, but before that, there is an important and often debated point, which is antibiotics. Should we use them or not when placing a drain? Actually, this is a controversial topic which with different opinions, but most agree that if the patient shows signs of sepsis, antibiotics are recommended. These patients are usually already on antibiotics, but there are two situations where antibiotic coverage is mandatory. Okay, first is the urinary obstruction, okay, and cases of biliary obstructions. These are the two cases where we strongly prefer antibiotics to be given within 1 hour before the procedure, because manipulating during the placement of the drain can easily trigger bacteremia and the patient may go into sepsis. So, in urinary and biliary obstruction cases, especially with infection or sepsis, make sure antibiotics were given within 1 hour. Okay? Many patients already receive antibiotics at midnight, but if the procedure is, say, at 8 a.m., another dose must be given before starting. Okay. Now, drains placement can be done under CT or ultrasound guidance, and the choice depends on your comfort level. If ultrasound clearly shows the collection and the surrounding critical organs, okay, the procedure can be safely done under ultrasound. It's usually easier and more convenient than CT, but if the collection is surrounded by bowel loops like this, with only a very narrow safe window, then CT guidance is better option, as it shows the full anatomy and allows safe planning. There are two main techniques for percutaneous drain placement. The first is the Seldinger technique, which is over the wire, which we discussed before. Okay, and the second one is the trocar technique. Okay, in the trocar technique, no wire is used. Just a sharp stylet is inserted inside the drain. Then the entire drain trocar set is advanced directly. Okay, so if this is the body, okay, and this is collection, we go straight into the collection with the setup. Let me show you the setup so you can clearly see